Hello, and welcome to this educational video. My name is Kathleen Jodoin. I'm an infectious disease pharmacist currently serving as the clinical coordinator and antimicrobial stewardship pharmacist lead and learning experience preceptor at Mount Sinai Medical Center. I've been part of the COVID-19 continuum of care since the start of the pandemic, leading the rollout of COVID-19 medication treatment pathways and order sets at our institution, which also served as a clinical trial site for Veklury prior to FDA approval. Here with me today is Dr. Onyema Ogbuagu. Can you please tell us a little bit about yourself and your role in the care of patients with COVID-19?
Hello, Kathleen, and thank you. And hello to our viewers. My name is Onyema Ogbuagu, and I'm an infectious disease specialist at the Yale School of Medicine, where I direct the antivirals and vaccines research program, including serving as principal investigator on multiple COVID-19 treatment and vaccine trials and research. I also practice at the outpatient Yale Center for Infectious Diseases, as well as Yale New Haven Hospital, where I care for patients with COVID-19, both inpatient and outpatient.
So today we'll be discussing the current state of COVID-19 and insights into clinical practice. So during this discussion, we'll focus on a number of topics, including the role of Veklury, known commonly by its generic name remdesivir. And more specifically, we'll review a variety of data related to disease progression, time to recovery, readmission, and mortality, as well as the safety profile of Veklury. So to get started, let's review the indication and some important safety information for Veklury. Veklury is indicated for the treatment of COVID-19 in adults and pediatric patients less than 18 years old who weigh at least 1.5 kilograms, who are either hospitalized or not hospitalized with mild to moderate COVID-19 and are at high risk for progression to severe disease, including hospitalization or death. Veklury is contraindicated in patients with a history of clinically significant hypersensitivity reactions to Veklury or any of its components. So Onyema, we've come a long way since the start of the COVID-19 pandemic. Our healthcare systems were simply overwhelmed during the initial surge of 2020 and the waves that followed. And while the virulence of the Omicron variant has decreased compared with prior variants, even today, COVID-19 remains unpredictable and continues to place a significant burden on hospitals and staff.
I certainly agree, Kathleen. I think COVID-19 has definitely put extreme pressure on our hospitals, healthcare workers, and patients. Since 2020, there have been over 100 million cases, more than 6 million hospitalizations, and greater than 1 million deaths in the United States alone due to COVID-19. In 2021, COVID-19 was the third leading cause of death in the United States. And even more recently, in the 12 months from October 2022 to September 2023, approximately 85,000 people died of COVID-19, a death toll that's about 4 times higher than the flu during the same time frame. And my concern is that vaccine-induced immunity is also waning, and there is a low uptake of the updated COVID-19 vaccines. In fact, only about 22% of US adults have received the 2023-2024 vaccine, and as a result, many people may still be vulnerable to the virus.
So let's talk about specific COVID-19 treatments next. First, I'll review some important safety information for Veklury. With warnings and precautions, we want to call out that hypersensitivity, including infusion-related and anaphylactic reactions, has been observed during and following administration of Veklury, and most reactions occurred within 1 hour. So it's important to monitor patients during infusion and observe them for at least 1 hour after infusion is complete for signs and symptoms of hypersensitivity as clinically appropriate. Symptoms may include hypotension, hypertension, tachycardia, bradycardia, hypoxia, fever, dyspnea, wheezing, angioedema, rash, nausea, diaphoresis, and shivering. Slower infusion rates, note that the maximum infusion time is 120 minutes, can potentially prevent these reactions. If a severe infusion-related hypersensitivity reaction occurs, immediately discontinue Veklury and initiate appropriate treatment. Also to note, transaminase elevations have been observed in healthy volunteers and patients with COVID-19 who received Veklury. These elevations have also been reported as a clinical feature of COVID-19. Perform hepatic laboratory testing in all patients and consider discontinuing Veklury if ALT levels increase to greater than 10 times the upper limit of normal. and discontinue Veklury if the ALT elevation is accompanied by signs or symptoms of liver inflammation. Also, the co-administration of Veklury with chloroquine phosphate or hydroxychloroquine sulfate is not recommended based on data from cell culture experiments, which demonstrate a potential antagonism, which may lead to a decrease in the antiviral activity of Veklury. For Veklury, the most common adverse reaction, greater than or equal to 5% of all grades, was nausea, and the most common lab abnormalities, greater than or equal to 5% of all grades, was increase in ALT and AST. Continuing our discussion, Onyema, can you please share with us what information you use to guide decisions for treatment in patients with COVID-19?
Yes, Kathleen. The most important resource we use are the NIH COVID-19 treatment guidelines, as they provide evidence-based recommendations for how to manage the treatment of patients with COVID-19. But in addition to that, I also layer on my clinical judgment to determine the best course of action for each patient. As you know, there are always nuances to each case that may impact treatment decisions. We consider, patient-specific factors like age, comorbidities, and certainly the severity of COVID-19, so we can determine the appropriate course of treatment. And depending on these factors, we will initiate antivirals, corticosteroids, and/or other immunomodulators. So, what is your approach, Kathleen?
We also use the NIH COVID-19 treatment guidelines, which help guide our inpatient order set. We limit the use of corticosteroids to patients with more advanced disease requiring supplemental oxygen, which aligns with the NIH guidelines. We usually initiate Veklury early for our inpatients with COVID-19, really as a standard of care across a broad range of disease severities, including those with mild to moderate disease who are at high risk for progression.
We also use Veklury across a broad range of adult inpatients, including those that are at high risk for progression to more severe disease, and I would also consider it a standard of care. In fact, this is supported by the NIH guidelines, which recommend Veklury for hospitalized adults at high risk for progression to severe COVID-19 who do not require supplemental oxygen. It's also recommended for adults who are receiving conventional oxygen and as a part of the treatment regimen for certain adults who require high-flow nasal cannula or non-invasive ventilation. We also try to initiate Veklury as early as possible, which makes sense if you consider the pathogenesis of the disease.
There were 2 pivotal trials for Veklury that led to its approval in these 2 settings of care, ACT-1 and Pine Tree. So could you briefly go over the ACT-1 study and its results?
Sure, Kathleen. ACT-1 was an NIH-sponsored, randomized, double-blind, placebo-controlled clinical trial involving 1,062 hospitalized adult patients with mild, moderate, or severe COVID-19. In that trial, the primary endpoint was time to recovery within 29 days after randomization. And recovery was defined as either no longer hospitalized or hospitalized, but no longer requiring ongoing COVID-19 medical care. Now, patients included in this study were older, on average 60 years of age. Approximately 80% of patients had at least one coexisting condition, and 45% of patients presented more than 9 days after symptom onset. Ultimately, the study demonstrated a 5-day shorter recovery time with Veklury compared to placebo. Additionally, compared to placebo, Veklury reduced the incidence of new mechanical ventilation, or ECMO, or new non-invasive ventilation or high-flow oxygen in patients who did not receive either at baseline. Now, these outcomes were important to me at the time of publication, and they continue to matter since getting my patients to recovery sooner and reducing disease progression are top priorities.
And did the ACT-1 study look at mortality in this patient population?
It did, Kathleen. ACT-1 included overall mortality as a pre-specified secondary endpoint. The reduction in mortality in the overall population by day 29 was 15% with placebo, compared with 11% with Veklury. Now, this result was not statistically significant, but it's important to note that ACT-1 was not powered to evaluate a difference in mortality in the overall population. There was an additional post hoc subgroup analysis done that showed that Veklury led to a 70% reduction in mortality compared with placebo in patients receiving low-flow oxygen. This was notable since the low-flow cohort included the largest number of patients in the study.
Thank you, Onyema. And what did the ACT-1 study show relative to the safety profile of Veklury?
In ACT-1, the frequency of adverse reactions was comparable in the Veklury and placebo groups. In addition, laboratory abnormalities were also comparable between patients taking Veklury and those taking placebo. Now, Kathleen, would you like to share insights about Pine Tree?
Sure. Pine Tree was a randomized, double-blind, placebo-controlled trial in 562 high-risk patients who were not hospitalized and had mild to moderate COVID-19 for up to 7 days. These patients were randomized 1-to-1 to receive either Veklury or placebo for 3 days, and the primary endpoint was a composite of COVID-19 related hospitalization or death from any cause by day 28. The trial showed that Veklury significantly reduced the risk of COVID-19 related hospitalization or all-cause death by 87% compared with placebo. No deaths occurred in either arm of the study. As for the safety profile, the findings were consistent with those seen in ACT-1. The incidence rates and types of adverse events observed were similar between Veklury and placebo. Before we move on, I'd like to cover some important safety information on the dosage and administration of Veklury. Administration should take place under conditions where management of severe hypersensitivity reactions such as anaphylaxis is possible. For patients who are hospitalized, Veklury should be initiated as soon as possible after diagnosis of symptomatic COVID-19. For patients who are hospitalized and do not require invasive mechanical ventilation and/or ECMO, the recommended treatment duration is 5 days. If a patient does not demonstrate clinical improvement, treatment may be extended up to 5 additional days for a total treatment duration of up to 10 days. For patients who are hospitalized and require invasive mechanical ventilation and/or ECMO, the recommended total treatment duration is 10 days. For patients who are not hospitalized, diagnosed with mild to moderate COVID-19, and are at high risk for progression to severe COVID-19, including hospitalization or death, the recommended total treatment duration is 3 days. Veklury should be initiated as soon as possible after diagnosis of symptomatic COVID-19 and within 7 days of symptom onset for outpatient use.
Thank you, Kathleen. So now let's shift our focus to another study, one that provides additional mortality data for Veklury.
I'm assuming that you're referring to Solidarity?
That's right. Allow me to summarize it. Now, Solidarity was a large, international, open-label, randomized trial in 8,275 patients hospitalized with COVID-19. In that study, patients were randomly assigned to either the Veklury or control group. And the primary endpoint of the study was in-hospital mortality subdivided by disease severity at study entry. Mortality in the overall population was 14.5%, with Veklury compared with 15.6% in the control arm, although this was not statistically significant. Now, despite that, Veklury led to a 13% relative risk reduction in mortality for a subgroup of patients on low-flow and high-flow oxygen compared with the control arm, and this was statistically significant.
So the results from Solidarity provided additional mortality data beyond what we saw in ACT-1 for patients on low-flow oxygen and the overall patient population.
That's correct. And are there real-world studies that evaluated the impact of Veklury on mortality?
Yes, a real-world retrospective study examined mortality in adults who were treated with Veklury versus those who were not treated with Veklury across the pre-Delta, Delta, and Omicron variant periods. Since the study period was from December 2020 to April 2022, it included both the BA1 and BA2 variant periods. Data were obtained from the PINC AI Healthcare Database, which is a U.S. hospital-based, all-payer database, which covers approximately 25% of all U.S. hospitalizations from 48 states. The primary endpoint was all-cause in-hospital mortality, and data were analyzed across 4 supplemental oxygen groups and 3 variant periods. Supplemental oxygen subgroups included no supplemental oxygen, low-flow supplemental oxygen, high-flow oxygen or non-invasive ventilation, and lastly, invasive mechanical ventilation or ECMO. This was a large study in which over 200,000 patients with a primary COVID-19 diagnosis were analyzed. Roughly 164,000 Veklury patients were matched to 48,000 non-Veklury patients using preferential same hospital matching. The 48,000 non-Veklury patients were equivalent to the 164,000 Veklury patients based on one-to-one matching with replacement. So what does one-to-one matching with replacement mean? This means that control or non-Veklury patients could be reused and matched with multiple Veklury-treated patients. Patients included in this study were at least 18 years or older, must have been admitted to the hospital between December 1st, 2020 and April 30th, 2022, and had a primary discharge diagnosis of COVID-19 flagged as present on admission. Patients were excluded from the study if they were pregnant, had incomplete or erroneous data fields, were transferred to or from another hospital, were transferred from hospice, were admitted for an elective procedure, were discharged or died during the first 2 days of hospitalization, or lastly, if Veklury was initiated after the first 2 days of hospitalization.
So, Kathleen, while this study included a large sample size, impressive size, and matching that accounted for key factors, we do know that real-world studies have limitations. So, what were the limitations in this study?
There was a potential for residual confounding due to unmeasured variables. Additionally, the analysis could not account for some information that just wasn't included in the database, such as time from symptom onset, viral lineages, and pre-hospital care. Ultimately, the study showed that there was a statistically significant reduction in mortality by day 28 across all subgroups requiring any level of supplemental oxygen. And what's unique about this study is it demonstrated that Veklury was associated with reduced mortality in patients not requiring supplemental oxygen, and also in those requiring invasive mechanical ventilation or ECMO.
So, speaking of real-world studies, let's discuss one that evaluated the impact of Veklury on readmission. The PINC AI healthcare database was used to examine rates of 30-day COVID-19 related readmission and 30-day all-cause readmission after COVID-19 hospitalization among patients who received Veklury during their initial hospitalization versus those who didn't. Now, the study looked at data from May 2020 to April 2022, and in total, the population amounted to about 440,000 patients, with roughly 248,000 treated with Veklury. Now, the study population did have some differences that are important to consider, especially when looking at real-world data. When compared with the control group, Veklury patients were younger and were more likely to have a higher supplemental oxygen requirement during their index COVID-19 hospitalization. Now, when compared with non-readmitted patients, readmitted patients tended to be older, had more comorbidities, and were less likely to require low-flow supplemental oxygen. At this point, let's discuss some important limitations for this real-world study. Generally, real-world studies should be interpreted based on the type and size of the source datasets and the methodologies used to mitigate potential confounding or bias. They should also be considered in the context of all available data. Anyone evaluating these studies should be aware that results may vary between real-world studies. In this particular readmission study, some key limitations included the following. First, patients readmitted to a different hospital were not accounted for due to limitations of the data source. Second, since the model adjusted for multiple variables, patients were not matched. And finally, the study did not account for the number of Veklury doses administered. Now, the main takeaway from this study is that patients treated with Veklury had significantly reduced readmission rates. And notably, in the overall cohort, patients were 40% less likely to experience a COVID-19 related readmission within 30 days compared to those who were not treated with Veklury. This statistically significant reduction of 30-day COVID-19 readmissions was observed across all supplemental oxygen requirements and variant periods, including the pre-Delta, Delta, and Omicron era. Additionally, in the overall cohort, patients treated with Veklury were 27% less likely to be readmitted for any cause within 30 days compared with those who did not receive Veklury. A statistically significant reduction in 30-day all-cause readmission was consistent across all variant periods. It was also observed across all supplemental oxygen requirements with the exception of invasive mechanical ventilation and ECMO group, who failed to meet statistical significance due to a low sample size. These results demonstrate the importance of continuing to study medications like Veklury in real-world settings after they've been approved. Real-world studies are helpful to see how treatments perform in broader patient populations and contexts other than in clinical trials.
I've also had recent discussions on the use of Veklury in certain populations, such as patients with hepatic impairment.
Well, the FDA expanded their approval of Veklury to indicate that patients with mild, moderate, or severe hepatic impairment, those with Child-Pugh class A, B, or C disease, can be treated with Veklury without needing a dose adjustment. It's important to note that there are hepatic monitoring requirements outlined in the important safety information. And they read as perform hepatic laboratory and prothrombin time testing prior to initiating Veklury and during use as clinically appropriate. And as we mentioned earlier, clinicians should consider discontinuing Veklury if ALT levels increase to greater than 10 times the upper limit of normal, and discontinue Veklury if ALT elevation is accompanied by signs or symptoms of liver inflammation. Kathleen, initially there were no data available for Veklury use in patients with advanced chronic kidney disease and end-stage kidney disease. So as a clinician, it was challenging to figure out how to manage treatment in this high-risk patient population, as treatment options were either non-existent or limited for inpatients and outpatients respectively. But then the FDA-approved label was expanded for Veklury, allowing its use without dose adjustment across all stages of renal disease. And in reviewing the important safety information for Veklury, we see that no dose adjustment is recommended in patients with any degree of renal impairment, including patients on dialysis. And Veklury may be administered without regard to the timing of dialysis.
Thanks for that information. And following that label change, my institution updated our order sets, removing the restriction for use of Veklury in patients with renal impairment. There have also been more recent data on the use of Veklury in patients who are pregnant or breastfeeding. Available clinical trial data for Veklury in pregnant women have not identified a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes following second and third trimester exposure. There are insufficient data to evaluate the risk of Veklury exposure during the first trimester. Maternal and fetal risk are associated with untreated COVID-19 in pregnancy. For lactation, Veklury can pass into breast milk. The developmental and health benefits of breastfeeding should be considered, along with the mother's clinical need for Veklury and any potential adverse effects on the breastfed child from Veklury or from an underlying maternal condition. Breastfeeding individuals with COVID-19 should follow practices according to clinical guidelines to avoid exposing the infant to COVID-19. So with that, I believe we've covered all of our topics for today. Would you like to summarize some key insights before we close out, Onyema?
Certainly, Kathleen. For me, the composite of data supports Veklury as effective in reducing time to recovery and reducing disease progression, and is generally a well-tolerated antiviral for a broad range of patients with COVID-19 who are hospitalized or not hospitalized. Veklury is recommended in the NIH COVID-19 treatment guidelines for certain patients, and we've seen that real-world data have evaluated its impact on mortality and readmission.
Thank you for that great summary. It was wonderful to host this program with you, Onyema. Thank you for joining me.
Thank you, Kathleen, and thanks to all of you for joining us for this program.